Angiotensin blockade in late autosomal dominant polycystic kidney disease. Definition. The polycystic kidney disease (ADPKD) is a multisystem monogenic disease, which is predominantly characterized by the presence of multiple bilateral renal cysts, as well as external manifestations, cysts in other organs, vascular abnormalities, cardiac, digestive, and musculoskeletal, which develop varying degrees.
Angiotensin blockade in late autosomal dominant polycystic kidney disease. Background. Hypertension developed early in patients with autosomal dominant polycystic kidney disease and is associated with disease progression. The renin-angiotensin-aldosterone system is implicated in the pathogenesis of hypertension in patients with ADPKD. Dual blockade of the RAAS may circumvent compensatory mechanisms that limit the efficiency of monotherapy with an angiotensin converting enzyme inhibitor or angiotensin II receptor blocker. Method. In this double-blind placebo-controlled trial, we redoubling assigned in patients 8 to 64 years of age with ADPKD. With these dose adults to achieve a blood pressure of 110 to 7 to 138 mmHg. The composite primary outcome was the time to death end-stage renal disease, or a 50% reduction from the baseline estimate GFR. Secondary outcomes include the rate of change in urinary aldosterone and albumin excretion, frequency of hospitalization for any cause and for cardiovascular causes, incidence of plaque, frequency of ADPKD-related symptoms, quality of life, and adverse study medication effects. Patients were followed for 5 to 8 years. In results, there was no significant difference between the study group in the incidence of the composite primary outcome. The two treatments controlled blood pressure and lowered urinary aldosterone excretion similarly. The rate of decline in the estimated GFR, urinary albumin excretion, and other secondary outcomes and adverse events, including hyperkalemia and acute kidney injury, were also similar in the two groups. I imagine about the topic and conclusion. Monotherapy with an ACE inhibitor was associated with blood pressure control in most patients with ADPKD and stage 3 chronic kidney disease. The addition of an ARB did not alter the decline in the estimated GFR.
Etiology. ADPKD is the most common hereditary kidney disease, with a prevalence estimate to be 1/400 and 8,000, and is the third leading cause of end-stage renal disease (ESRD). It is a disease that occurs worldwide and affects our race equally.
Angiotensin blockade in late autosomal dominant polycystic kidney disease. For the definition, autosomal dominant polycystic kidney disease is an inherited condition that causes small fluid-filled sacs called cysts to develop in the kidney. The symptoms were tummy pains, high blood pressure, blood in the urine, potentially serious upper urinary tract infections and kidney stones. In treatment, the use of an ACE inhibitors as first-line agents to treat hypertension in patients with ADPKD has become a standard clinical practice. Two main alternative treatments are dialysis and kidney transplant. The pros and cons: the safety of both dual blockade of the AAS and rigorous blood pressure control was excellent. Procedures such as scans and MRI are expensive. Issue applying in Ecuador. Here in Ecuador, ultrasound is the most common form of diagnostic kidney cyst. By year is detect cases. Well, the conclusion, an ACE inhibitor was sufficient in the majority of patients with ADPKD. The addition of an ARB did not appear to confer an additional benefit.
Etiology and genetics. ADPKD is hereditary and as autosomal dominant with complete penetrance, so that each child of a affected parent has a 15% chance of inheriting the mutation. It's a genital code generate disease where there are two identified genes PKD1, PKD2. PKD1 individuals with mutations in PKD1 tend to have a more severe clinical presentation, but there is great variability in interfamily and domestic. PKD2 they have adequate renal function. Pathological anatomy. Cysts originate as focal dilatation of renal tubules, then they lost connection with them. In the early stage of the disease, the renal parenchyma has a relatively abnormal part.
Quick, I'll abbreviate it PKD in this video. And PKD is a familial disease. It's actually most commonly autosomal dominant, and therefore most clinical vignettes that you see on the licensing exams will have some sort of family history included in the patient presentation. Essentially what happens in PKD is that you have these genetic mutations, and they lead to a lot of formation of cysts in the kidney. And these cysts will be filled with fluids, and as a result, the kidney enlarges, gets bigger, and this can be detected. Now, one thing that is very common that they like to test on the licensing exams about PKD are actually what is happening outside the kidney, the extrarenal manifestations of polycystic kidney disease. And there's one in particular that in addition to problems with the kidney, the patient may also have aneurysms in the cerebral arteries, in particular the ones that are part of the circle of Willis. And these sometimes are known as berry aneurysms. That's the term given because they sort of resemble a berry, kind of look like that. And these may rupture, and if they do, it can lead to rather significant consequence of subarachnoid hemorrhage. So this is commonly tested as a complication of polycystic kidney disease. So What are some of the symptoms of polycystic kidney disease that a patient will present with? I'll present the three most important that you will see in an opening stem. The first is a flank pain, essentially the area of the kidney, or it might even be described as back pain. The next is hematuria, blood in the urine, and then long-term hypertension, high blood pressure. Also, it's not really a symptom, but it is part of the clinical vignette. There'll be some sort of family history. They'll talk about the siblings or the parents also having high blood pressure. Diagnosis. Well, without a doubt, the best initial test is a kidney ultrasound. Other tests are possible, but they're quite expensive, so this is the best initial choice. And what it will show is bilaterally multiple cysts in the kidney. And as a result, you will have renal enlargement due to these fluid-filled cysts. Other tests that you can do, definitely a urine analysis, because there sometimes is a risk of infection. Kidney tests such as BUN creatinine, because PKD can eventually lead to renal failure, slow progressive renal failure because of the cysts interfering with the normal parenchyma, the normal tissue. And if you suspect that this patient might have that dreaded complication of cerebral aneurysm, then definitely some sort of head imaging, such as a head CT or a MRA, magnetic resonance angiography, would be appropriate to do. In terms of treatment, really, PKD, the most important thing is control of the complications. So the complications, of course, the biggest one is high blood pressure. So that is really key, because that will help preserve the kidney function. And the most common medications used to control the blood pressure in the setting of PKD is ACE inhibitors. And if the patient does progress to renal failure, which definitely can happen, then unfortunately the patient has to go on hemodialysis.